Part 6 deals with some aspects of overlapping histology, particularly keratinisation and ghost cells. We come to case number 7. It's a 25-year-old female with an incidental radiolucency in the mandible, which is asymptomatic. And here you can see we have a well-defined and corticated multilocular radiolucency, which is extending from the area of the bicuspids to the sigmoid notch. And you can see on the occlusal radiograph that there is a distinct lack of buccolingual expansion, which is relevant in this case. Here is the appearances in the case that you'll have the virtual slide for, and it has a classic histological appearance of a fibrous connective tissue wall to the cyst and a lining, which is epithelial, 4 to 6 cells thick, and has a corrugated parakeratinized surface and basal cell palisading. I think this is quite a classic appearance, and the final diagnosis for case number 7 is an odontogenic keratocyst. The odontogenic keratocyst arises within the tooth-bearing area and has this characteristic lining as we've seen. It may replace a tooth, and it probably arises from remnants of the dental lamina, although there is very little evidence as to what may start the proliferation process. Sometimes in the retromolar area we will see little keratinous remnants of the dental lamina like this and wonder whether this is the sort of lesion in which odontogenic keratocyst starts to develop. So some features of odontogenic keratocyst: it's present mostly in males, most in the mandible, most in the lower third molar area, and a good proportion of them associated with an unerupted tooth. Posterior mandible segment associated with the most common site of dental lamina rest remnants. Very often, as we saw in our case, there's little or no buccolingual expansion. That can be a very useful feature in assessing this in comparison to differential diagnoses clinically, such as ameloblastoma or odontogenic myxoma. It has a classic histological appearance of this thin, stratified squamous epithelium, a parakeratinized surface, and basal cell palisading. The lining tends to be fragile, very easily separated from the connective tissue wall, and in some cases there will be proliferations within the connective tissue wall, which we refer to as daughter or satellite cysts. Here's a higher power again of the characteristic features of the lining of an odontogenic keratocyst: the parakeratinized corrugated surface and the basal cell palisading. The main problem with odontogenic keratocysts, as many of you are aware of, is the recurrence rate, and that varies markedly across the literature. We have to take into account a number of different features. For example, is the lesion associated with nevoid basal cell carcinoma syndrome? And these syndromic odontogenic keratocysts do have a greater risk of recurrence. The overall rate for all comers is about 20%, and in nevoid basal cell carcinoma syndrome about 35%. Multilocular tends to be higher. And also, it's very important in relation to the modality of treatment, and enucleation alone tends to result in a significant recurrence rate. The fragility of the lining and the presence of daughter cysts is also associated with recurrence. Here we have a keratinized cyst of the jaws with this rather budded and proliferating appearance. We sometimes get these cysts and we wonder really what it means. But there are a number of other features that may be associated with recurrence. What about variants of odontogenic keratocyst, and where do they fit into the story? Well, the orthokeratinized odontogenic cyst used to be part of the odontogenic keratocyst classification, but now in the 2017 classification has its own section. It comprises about 1% of jaw cysts and has a very similar site distribution to the classic odontogenic keratocyst. It tends, though, to have a very low recurrence rate, and the histological appearances are different from the classic odontogenic keratocyst in the fact that the epithelium is orthokeratinized and very often has a granular layer to the epithelial lining, as you can see here. Sometimes they are multiple. We have published a short series in Head and Neck Pathology last year of these. What is not known is what relation these may have to syndrome or any other disorder. Which brings us to syndromic odontogenic keratocysts. And it's important to remember before we talk about them that not all multiple odontogenic keratocysts are syndromic, but a good proportion of them are, and they are associated most often with basal cell nevus syndrome, Gorlin-Galt syndrome, whatever you may call that with its different names. And those patients have multiple recurrent odontogenic keratocysts, along with other features, including basal cell carcinomas of the skin. And you can see in the panoramic radiographs, you can see here that the multiple radiolucent lesions are identified. So what are the clues for syndromic cysts? I showed you a histology of basal budding a few slides ago. Is that associated with a syndromic cyst? Well, according to the overall analysis, no. It is the presence of satellites or daughter cysts and also solid islands, which are particularly related to syndromic cysts. Immunohistochemical analysis for that is not particularly helpful, and in fact, in some cases, might be confusing. Then variant 3, the solid odontogenic keratocyst. And what about this? Well, this is still a controversial issue, and it may be that, in fact, given the fact we're going to talk in a minute about the nature of these cysts, that this is the neoplastic variant and the cystic lesions are developmental cysts of the jaws. But that is still controversial, and there's still a lot of work to be done in that area. So as I indicated, there is a controversy about the odontogenic keratocyst. The 2005 classification removed odontogenic keratocyst and replaced it with the term keratocystic odontogenic tumour, which was not really very well defined as far as its diagnostic criteria are concerned. Then in the 2017 classification, keratocystic odontogenic tumour is out of favour, and the term odontogenic keratocyst was re-entered into the classification. I don't think that this is yet an issue which is settled, and we may have still to identify cysts which are truly developmental cysts of the jaws, and there may be a proportion of lesions which are neoplastic. We do not yet have the tools to be able to confidently separate these. What about other challenging areas in odontogenic keratocysts? Well, the presence of concurrent inflammation is important, and some others that I'm just going to very quickly run through. The odontogenic keratocyst loses its characteristic histological appearances when it's inflamed, and that can be very challenging for diagnosis, but also means that you may have to make sure that the whole of the specimen has been submitted and carefully examined. And you can see in areas, particularly on the left-hand photo micrograph, just how the classic appearance just completely disappears. Focally, it's present here in this area of inflammation. Some odontogenic keratocysts are not enucleated, they are marsupialized. A window is cut into them, and that window is remained open, and then the lesion is then left to infill. The eventual enucleation specimens can be challenging because there can be very little classic odontogenic keratocyst left, and in some cases it becomes a rather hyperplastic stratified squamous epithelium, as can be seen in the lower panel. And then, of course, there are the fact that other odontogenic cysts focally can have keratinization, and it's important not to overcall that. Keratin is present in 2% of radicular cysts. It also can be present focally in dentigerous cysts and also in ameloblastoma. So it's important to pay attention to the whole lesion and the context in which that keratinization arises. And then there are, getting into further area of controversy, hybrid cystic lesions, which are very rare, and we occasionally have these. This is one that we had recently, which is a keratinized area and then a glandular odontogenic cyst-like area very closely associated with it. And I think these just are not true hybrids, they just represent the plasticity of odontogenic epithelium. Very quickly, let's move on to ghost cells, and this is another area of challenge with these cells which are present sometime in a number of odontogenic lesions. So what are ghost cells? Well, there's a little bit of controversy about this. Are they aberrantly keratinized cells? There seems to be very little good evidence for that. And in fact, most of the proteins which have been identified in these cells are enamel-related proteins. Others have suggested it's a coagulative type of necrosis. The classic example of a lesion with ghost cells in the jaws is the calcifying odontogenic cyst, which has been returned in the 2017 classification to a benign developmental cyst, which is present largely in younger patients in either jaw and can have calcifications on radiology. In histology, the lining tends to be quite ameloblastomatous, but has areas of ghost cells, may also have production of a dentinoid type material, and very often they're associated with an odontome, although not always. So here are ghost cells, the epithelium, you can see a little remnant of that underneath the ghost cells, but they are these kind of coagulated appearance with the ghostly outline of the cell and the loss of the nucleus, which is classic for ghost cells. In this case, there's a hairpin here of a kind of dentinoid material related to that, which we do sometimes see. But we see ghost cells on a number of different lesions in the jaws. Focally, sometimes we see them in ameloblastomas, as I say, classically associated with odontomes, and then extensively in the dentinogenic ghost cell tumour and its malignant counterpart. Very focally, here's an example of a little focus of ghost cells, which we had in relation to an odontome. The ghost cells are seen in the epithelium on the left-hand panel, and the odontome, which was present, on the right-hand panel. And then the dentinogenic ghost cell tumour, which is formally regarded as the solid variant of the calcifying odontogenic cyst, which we see from time to time, and maybe central or peripheral, and in many cases we see them peripherally presenting in the jaws. And then the very rare ghost cell odontogenic carcinoma, with very small number of cases reported in the literature. And these tend to present with ghost cells within the histology, but with other characteristic appearances of malignancy. There's also the question raised, well, is this progression from a calcifying odontogenic cyst? And that's a question which we really can't answer as yet. So what about the important features? So that odontogenic epithelium is very plastic, so therefore you're going to see keratinization and ghost cells and very divergent differentiation. Keratinization can be present focally in many odontogenic lesions, so don't be caught out with that. And ghost cell lesions, they are a wide range of odontogenic lesions can contain these, and the terminology really is confusing and probably does need to be refined.